our treatments, really important to start with the concept, of course, that detox alone or detoxification alone is not very effective and should not be considered treatment by itself. And I start with this concept because still, despite sort of, lots of data, many people, certainly in the population, but also within physicians, providers, treatment community clinicians, seem to automatically think of detoxification when we think about treatment for opioid use disorder. But what we know is that detox alone, it may be a sort of a part of an overall treatment, but when it comes to opioid use disorders, detox alone is not very effective. It simply does not work. This is a quote I know Dr. Jacobson and I both like to use by Walter Ling at UCLA. Detoxification from heroin is good for many things, but staying off heroin is not one of them. Simply doesn't work. But for a long time, certainly here in the United States and many other parts of the world, we kind of thought about detox or drug-free approach. That's kind of been the tradition, right? In sort of Western medicine, when we think about people with substance use disorders, it's what's been traditionally used. And it may in fact work for a small subgroup of people. These people are generally highly motivated. They're generally overall stable. Certainly less than 20% of people, likely far less than 10% of people with opioid use disorder may benefit from detox alone without subsequent medication support. But we have no good way to predict who that 10% may be, right? So a vast majority, unfortunately, following detoxification will simply return to using illicit opioids. And as you can see here, up to 90% of patients who've been detoxified relapse or return to using illicit opioids very quickly, within 1 to 2 months, and has been shown that of those that relapse, return to using illicit opioids, some will die of an overdose. So I think that's sort of the grave consequence that we must keep in mind. So I really that's sort of one take-home point, that we don't want to be encouraging or recommending detox alone as treatment. It is not evidence-based. This is the classic study done by Kako back in 2003. Took all the patients, in this study, everyone had opioid use disorder. One group, the group with these red circles up here, are people who got maintained on buprenorphine, and these green squares are people who were detoxified, over a 1 week period, and then followed, maintained on placebo. So, they didn't know no one knew what they were doing, and first thing they looked at was treatment retention. And you can see that at 1 year mark, people who were maintained on buprenorphine, about 75% of them were in treatment. And that's good, right? We want to keep people in treatment. That's when we can really help them. And you can see that the people who were detoxed and then put on placebo or sugar pill, within just 2 months, everyone had dropped out of treatment. And more than that also, and additionally, at the 1 year mark, there were no mortalities in the buprenorphine maintained participants. So everyone was alive, but there were 4 mortalities. That's really about 20% actually of the population, that sample, were no longer alive just at the 1 year mark. So fairly dramatic, right? And just one of many studies showing very similar things. So detox alone isn't very effective. And when we talk about opioid use disorders, medications approved by the FDA for opioid use disorders, I would argue, play a very central role in treatment. In fact, according to the National Institutes of Sciences and Medicine, Engineering and Medicine, it should not be considered appropriate treatment unless we are treating someone with opioid use disorders with one of our FDA-approved medications. They're very clear about it based on data. I start with outcomes from methadone, which is one of our 3 FDA-approved medications, because that data is very, very strong. You can see here that with methadone maintenance or ongoing treatment, you conservatively get heroin use reduction by about 50%. In many studies, far more than that. You get reductions in HIV transmissions, increases in employment, reductions in criminal activity, less incarceration, less high-risk behaviors, more child support payments. People are more likely to remain in treatment, complete Hep C treatment. Mortality is reduced, and this has been shown with both methadone and buprenorphine, significant mortality reductions in multiple studies, and they're cost effective. And you also get these additional kind of harm reduction benefits, including improvements in high-risk behaviors. So a lot of things have been shown. This is, again, a reference slide, an old study. UNM was actually one of the sites for this study that was published almost 3 decades ago, showing kind of crime before and after entering MMT or methadone maintenance treatment. And you can see significant reductions in, people engaging in criminal behavior. So it's likely driven by people, using and purchasing heroin, but you can see significant reductions in that. Also, while medication is the centerpiece, other treatment, right, can be arranged around it. It may allow us to provide psychotherapy, case management, right, healthcare. It's the hook around which we can organize the rest of the treatment. Allows us to treat the underlying medical and psychiatric conditions, as well as working on those really important things like building those social networks, working with our clients, right, engaging with them, supporting them as they re-engage with communities and work towards their purpose and involvement. And so I think medication forms the structure around which this is often organized. In the next several minutes, I'm going to go into what our FDA-approved medications are. Again, just an overview. The first medicine that's been approved since the 1970s, methadone, was approved by the FDA for maintenance treatment of individuals with opioid use disorders about 5 decades ago. I believe it was in 1973 or 74, so almost 5 decades ago. It's a Schedule II medication, so it's highly regulated and can only be prescribed or dispensed, rather, when it's being used for the treatment of opioid use disorder out of opioid treatment program or narcotic program treatment program settings. It's a full mu agonist. So for some patients with a high degree of baseline tolerance, or people who have tried naltrexone and buprenorphine and they haven't maybe been successful, methadone can actually be a very good option. And some of our patients opt to, right away go on methadone. And again, patient choice is important. They are the experts, right? Our clients, our patients are the experts on their own bodies, their own lives, and we take that into our overall account, and certainly want to respect that. So generally, it's a medication that, it's very effective. It's been shown, I've shown some of the outcomes already, robustly shown to reduce mortalities, but there are treatment barriers to methadone. It is out of the medical mainstream. Again, people have to go to opioid treatment programs to receive it. There may often be stigma of these specialized clinics. Often the clinics, right, might be located in edges of town, or they're large swaths of the country, including here in New Mexico, where accessing an opioid treatment program, a methadone clinic, can be very difficult, right? There are communities here in New Mexico where the nearest opioid treatment program is several hours away. And because of the federal regulations, historically, patients have had to go to the clinic several times a week. So imagine living several hours away from a clinic, needing to travel there several times a week. How do you have a job, right? How do you do other things? What about the cost of gas and transportation? That can create a real barrier. And that historically has limited the use of methadone. And really the national slots of methadone treatment have been largely plateaued for the last 2 decades, even as the opioid epidemic has raged. The second FDA-approved medication, and what has been the focus of our ECHO program here, is buprenorphine. It's a partial agonist medicine. So in other words, up until a certain dose, the higher the dose, the more it activates those mu-opioid receptors, but then you get a nice plateauing. So someone can keep taking more and more and more buprenorphine, but won't get further activation of those receptors. And the one obvious and clear benefit of that is there is significantly less risk of overdose when people are on buprenorphine compared to methadone. And it literally took an act of Congress, the Drug Abuse Treatment Act of 2000, which made possible office-based prescribing of Schedule III opioids. And because buprenorphine is a Schedule III medicine, buprenorphine is covered under what's called the Data 2000 Act that allows, initially it was physicians alone, but then under the CARA Act, also NPs and PAs, and then under the Support Act, clinical nurse specialists, nurse midwives, nurse anesthetists, to complete a required training and then be able to prescribe buprenorphine out of their offices to treat individuals with opioid use disorders. So it's a partial agonist, as I mentioned, as opposed to methadone, which is a full agonist. And the clear benefit of that is buprenorphine has a significantly less potential for unintentional overdoses. It's available as both films and tablets, which are taken under the tongue. There is also implants, which are no longer on the market at this time, but there is a long-acting injection. There's going to be another long-acting injection that will be coming on the market soon, which are given generally once every 4 weeks. There are also patch and buccal formulations as well as IV buprenorphine, but those are more used in pain management settings and not in the setting of opioid use disorder. Generally, the dose range is a lot narrower compared to methadone. So, usually people start getting a ceiling effect at doses of 24 to 32 milligrams. And the dose range is really 4 to 32 milligrams. Historically, we always said that most people on buprenorphine do fine at 16 milligrams or less. But recent studies have shown that many people do better when we initially build them up to 24 milligrams, perhaps because what people are using is fentanyl, which is a highly potent opioid. So people are coming to us with these higher baseline tolerances, requiring higher doses of the medications. The key thing with buprenorphine is that initial dose is tricky and can lead to withdrawals if someone takes it when another opioid is still in the system. So a lot of the training actually focuses on how do you safely get someone started on buprenorphine. But the real benefits, so buprenorphine offers several benefits, right? Over methadone, it's certainly safer in overdose. You have fewer drug-drug interactions. You don't have to worry about the QT prolongation, which is sort of electric conduction through the heart, which you do have to be worried about with methadone. And then it's really patient-friendly, right? Allows a patient to see her physician, her provider, for that continuity of care, confidential care, and receive treatment for opioid use disorder as well. Prevents these costly trips, right? Needing to go to the clinic every day, allows the patient to lead his life, which is of course important. Works about as well as methadone in terms of effectiveness. It's as effective as methadone at reducing illicit opioid use, but maybe has slightly less treatment retention. So people on methadone tend to do better in terms of staying in treatment. And perhaps it's because some people just really need the structure provided by that methadone opioid treatment program setting. But largely the outcomes are about equal. And that's really what this Cochrane review that was done back in 2008 showed, that buprenorphine and methadone are roughly about equally effective. Our third FDA-approved medication is Naltrexone, which is an antagonist. So Naltrexone is not a medicine that activates our mu-opioid receptors. Rather, it binds those effectives and blocks them. So if someone uses another opioid, they don't get reinforcement. They don't feel a sense of high. It is available and approved as both a daily oral pill as well as a monthly injection. While both are approved by the FDA, the daily oral pill is actually not effective for treatment of opioid use disorder. So what we should be using if we use this medicine is the injectable formulation. And once started, what studies have shown is that naltrexone is about as effective as buprenorphine, but it is much, much harder to initiate. And that's what's limited actually the use of naltrexone in people with opioid use disorder. Up to a third of patients, even in controlled studies, simply leave before being able to start naltrexone because they have to get through withdrawal and get about 10 days without using any opioids before they can take naltrexone. And that's very hard for our patients with opioid use disorder, right? So how do we choose? So with that little introduction, how do we choose? And these are slides courtesy of PCSS, Providers Clinical Support System. But I'm gonna kind of summarize it. Patients for naltrexone, again, with naltrexone, the tricky thing is getting started. So if people have access to residential or inpatient settings where they can safely stay, that's gonna help. Also having a lot of support, right? Whether from family or friends, also from peer support specialists, right? Other clinicians, if they're able to really be supported during that abstinent opioid-free treatment, certainly that would be helpful in terms of getting started on naltrexone. So I think there is a lot that needs to be done. It generally works well for people who are highly motivated, people who don't wish to be on any opioids, or people who are not allowed to be on any opioids. For example, impaired physicians or commercial pilots who would not be allowed to be on methadone or buprenorphine. So naltrexone for them is a great option. Naltrexone, I've actually used a lot also in people who've been on methadone or buprenorphine. They've done well, they've been in abstinence, they've been in recovery. Now they're tapering off of those medication. They're almost done and they're starting to get worried. What happens when I stop my methadone? What happens when I stop my buprenorphine? Sometimes for those patients, we'll put them on injectable naltrexone once they've tapered off of their methadone or buprenorphine for a few months, while the patients build up their relapse prevention skills, their coping mechanisms. And when they feel ready, then we would stop the naltrexone. So that's a strategy we've used quite a bit. For example, patients actually with history of overdoses, particularly following detox, maybe they're better candidates actually for something like methadone or buprenorphine. Because remember, if someone's been on naltrexone and if they stop it, they've lost their tolerance. And if they go back to using what they were using before, they are at a high risk of overdose. And if that's already happened in history before, then perhaps we need to have the conversation that buprenorphine or methadone may be better options for them. Specifically, people with serious mental illness who are disorganized, maybe unstably housed or houseless, may do better with methadone, because that opioid treatment program can provide the structure, the support around which the rest of their care can be organized. If patients have chronic pain requiring chronic opioid treatment, then I'm not going to pick naltrexone. I'm going to really pick between buprenorphine and methadone for those patients. And in pregnant individuals, naltrexone is still not considered an evidence-based choice. So in pregnant individuals, that's actually one of our other topics that we do on a rotating basis. As we've shared, methadone and buprenorphine are really the things we think about. And of course, as I mentioned earlier, patient choice matters. So this is just a little buprenorphine methadone comparison slide for reference, also courtesy of PCSS. Just a couple of other slides as we come to the end here. One is, how long do I stay in treatment, right? That's a question that often comes up. And the answer is, for as long as it benefits the patient, just like we would do for all of our other chronic illnesses. In fact, we recommend, discouraging patients from discontinuing treatment too early in treatment, again, because what happens after treatment is stopped. For a majority of patients, unfortunately, they simply return to using illicit opioids. So we really want to be, we really want to discourage patients from stopping treatment too early in treatment. I generally tell my patients that, what are your goals? And I encourage them to stay on the medicine at least until those goals are met, until their lives are more stable, until their social networks are more supportive, and then really tapering if they want to at their own pace. I don't encourage, or certainly not pressure, but also don't encourage my patients to taper off of a medicine that's working. Just like I would not encourage a patient who's on metformin for diabetes to taper off of their metformin if their diabetes is well controlled. I wouldn't do it. Similarly, I don't do it for my patients with opioid use disorder. Again, just a reference slide, but at right doses of medication, the patient should feel quote unquote normal. That's what my patients tell me, that they shouldn't be in withdrawals, they shouldn't feel sedated, they shouldn't feel like they're nodding out, etc. Cravings may not be gone totally, but they should go down. Counseling can be really helpful, I find, for that craving management. If patients are on methadone, EKG should be periodically monitored. We tell our patients, if you're going to be on any medications, let us know so we can make sure that the medications are not going to interact. This is especially important with methadone. I also tell them, if you're ever going to have a surgery, if you're ever going to have a procedure, let me know as soon as you know you're going to have it, so we can talk to your doctors and make sure your pain is going to be well controlled and controlled in a safe way. Naltrexone cannot be combined with other opioids, including methadone and buprenorphine. It's very difficult to switch from methadone to buprenorphine, but not the other way around. So when I consider that and consider the overall safety profile of buprenorphine, my approach often is that, all things being equal, buprenorphine is a great initial choice, and reserving methadone really for patients for whom buprenorphine just doesn't work, or if they strongly don't prefer to be on buprenorphine, right? And let's see, lastly, something that Dr. Jacobson speaks really well about and knows a lot from experience, role of integrated clinics, right? Ideally, some of our patients who have really challenges accessing quality care, if we can organize all of their care, including primary care, treatment for hepatitis C, psychiatric care, case management, around their medication for opioid use disorder, that's a great opportunity, right? And studies certainly support that. So I really end with that plug, and I will stop here. Thank you.